Welcome to Pathology Central Key Concepts. Today's topic is laboratory evaluation of anemia. So this is a topic that just gets a couple short paragraphs in the Robbins pathology textbooks, but an understanding of how we evaluate anemia is critical for you so that you will be able to figure out the etiology of your patient's anemia. In addition, by having this initial discussion, it will help you to understand the pathophysiology of the different anemias. Now, there is one thing I'd like to preface this with, which is that what I'll be discussing is a basic medical student level laboratory evaluation of anemia. There are a lot of special tricks, some exclusions, some exceptions to the rule. For example, there are confounders, like if a patient has very high serum triglycerides, that can affect your CBC. We're not going to worry about any of that. This is just the basic knowledge that you as a medical student need so that you'll be able to understand anemia and how you come up with the etiology so you can treat your patient. All right, so without further ado, here are my objectives. Essentially, I'm going to go through the screening test for anemia and then the different categories of tests that we use so that we can really focus on what the cause of that patient's anemia is, because you have to understand the cause so you can treat the patient appropriately. So first of all, as always, let's begin by defining our terms. What is anemia? So basic definition, decrease in red cell mass. Since red cells carry oxygen, you will have decreased O2 carrying capacity in the blood, which will lead to tissue hypoxia. So how's this going to present? Is a patient going to walk into your clinic and say, "Hey doc, I'm anemic"? No, generally not. The most common way that you'll probably pick up on an anemic patient will be through a screening CBC, complete blood count. Because we do CBCs when patients come for their annual exam, whenever we suspect something is up with a patient, a CBC is a great test to get an idea of what's going on health-wise in that patient, similar to the basic metabolic panel. So you might pick up an anemia that the patient doesn't even know that they have any symptoms. The classic presentation will be someone who is more easily fatigued, has some weakness. In more advanced anemia, perhaps dyspnea on mild exertion. Sometimes we'll refer to a patient as having pallor or being pale. And this can refer to the skin color, but because of variations in skin pigmentation, this may not be as useful. So on clinical exam, what you'll really want to be looking at will be the conjunctiva, the tongue, the nail beds, and the palms. For me personally, I prefer the conjunctiva because it has sort of a nice internal control. Here you can see in a healthy individual, you pull down the lower eyelid, you see the conjunctiva, and the anterior portion is this nice dark pink with a slightly lighter pink here in the posterior portion. By contrast, in this individual with anemia, you can see there is just this generalized pallor throughout the entire conjunctiva. There is no darker rim here at the front. So we have a patient, we think, okay, this patient may be anemic, we do our CBC, and we want to figure out, well, what is the cause? Well, here are the three broad categories of causes of anemia and then some more details. Now, I know this is a little bit overwhelming, and it's intended to be so, because when you recognize how many causes there are of anemia, you recognize how important it is to understand the laboratory tests so you can find the cause for your patient. So our first one we'll think about is blood loss, and that can be acute due to trauma, which shouldn't cause much diagnostic difficulty. Now, chronic anemia from blood loss can be from, say, a colon carcinoma, a chronic gastritis, some sort of gyn pathology. And what we'll see in this type of anemia is typically going to be an iron deficiency anemia, as that patient is constantly, slowly shedding blood. The other two categories to think about are hemolysis, so you have destruction of blood cells, and the other is decreased production. You're not making enough. So the hemolytic anemias can be due to inherited genetic defects like hereditary spherocytosis or G6PD deficiency, both of which are covered in Robbins. We have our hemoglobin abnormalities like sickle cell disease and thalassemia, antibody-mediated destruction, mechanical trauma, so that could be, for example, a mechanical heart valve. We have infections and toxins, etc. Now, decreased production can also be due to an inherited genetic defect. Once more, thalassemia is something to consider. Nutritional deficiencies like vitamin B12, folate, and iron can also lead to decreased production. As you'll recall, the kidney generates erythropoietin, which is what stimulates red cell production. So if you have a patient who is in renal failure, they may not be putting out enough EPO, and your patient will have anemia. We've got infection, and then there are also whatever is in the bone marrow that may be impeding production by taking up space. So if you have a hematopoietic neoplasm and your marrow is chock full of blasts and cells that aren't making erythrocytes, that can lead to decreased production. Similarly, if you have a space-occupying marrow lesion like a metastatic carcinoma. Okay, so looking at all of these, how are we going to figure out what our patient has? So these are the general categories of tests that we use to come up with our diagnosis. So the first set I refer to as just red cells, right? We want to know what is going on with the red cells. How many? What do they look like? How variable are they in size? Our next consideration will be iron, because iron deficiency anemia is a significant presentation. Iron deficiency is a significant cause of anemia, so we want to check that out. Now, if you're thinking you might have a hemolytic anemia, there are a variety of tests like unconjugated bilirubin and serum haptoglobin, which will help you identify if hemolysis is occurring. And then if you're thinking about one of the megaloblastic anemias or macrocytic anemias, you'll want to look at your folate and serum and vitamin B12 levels. Hemoglobin electrophoresis we use to look at different variants of hemoglobin, like hemoglobin S or hemoglobin C. And then if we're concerned about an immunohemolytic anemia, we want to do the Coombs test, also known as direct antibody test, which will help us detect antibodies and complement that are bound to red cells. And then, of course, as pathologists, we always like to take a look. The peripheral smear is going to give us a lot of information regarding the size and shape and morphology of these red cells, as well as what else might be going on in the blood. So let's go ahead and get started. The first thing we think about when we're thinking about anemia is number of red cells. Do you have enough? Now, your screening test is going to be your CBC, which is going to give you a bunch of freebies, right? So what we're really interested in that CBC is going to be our hematocrit and our red cell indices. But the freebies, and we're talking here just about anemia. Obviously, you're interested in white blood cells and platelet counts if you're looking at infection or thrombophilia. But in the context of anemia, red cells, white blood cells, and platelet counts, and even hemoglobin are more or less a freebie. They come along for the ride. What we're really concerned about is our hematocrit. So the hematocrit is the volume of packed red cells in a centrifuge sample. So we take that blood tube, we spin it down, and we just measure how much of this is packed red cells. And it's about 3 times the hemoglobin, assuming the red cells are normal in size and shape, because that's going to affect how they pack down. And this is what your attending will ask you. Say you have a patient who's just had surgery and you've gotten your CBC. The question is going to be, so what's the hematocrit? They're not going to be as concerned about, what's the hemoglobin or what's the red cell count. The hematocrit is how we basically keep an idea of what's going on as far as anemia goes. Now, one thing to keep in mind is that hematocrit and hemoglobin are both affected by blood volume. So if your patient is dehydrated, they're going to have a falsely elevated hematocrit and hemoglobin. If they're retaining fluid, or if you've just done fluid resuscitation on someone who is dehydrated, they will have a falsely decreased hematocrit or hemoglobin. And this is a trap for neophytes. So say you have a patient who's come in, is not doing particularly well, has some fatigability. You do a CBC and you see that the hematocrit is 30%. The patient's also dehydrated. You give a couple of liters of normal saline, and then your next CBC, the hematocrit has dropped from 30% now down to 26%. And this made me think initially this patient has a rapid bleed, and this is something urgent. Maybe they have an ulcer in the stomach that's ulcerated into a blood vessel. They're bleeding rapidly. No, what's happened is you have diluted out the red cells. Now, before we go on to the red cell indices, I want to make one comment about these laboratory tests that I'm showing you. You'll notice I don't include the reference values. That's because they differ by population. So we have a set of reference values we use at Duke University. There's a completely different set that is used at Mayo Clinic because it's based on looking at your population and what the mean and average is for your, and the range for your population. And also, you don't need to memorize these. You know, when you look at the patient's lab results, they'll have the normal values right next to it, and they'll generally indicate whether they're abnormal for you. So that's one thing to keep in mind. I do put the units here just so you get an idea. Hematocrit is percent, hemoglobin is grams per deciliter, etc. Okay, so now let's get on to our red cell indices. So of these I've mentioned here, your hematocrit's the one you're focused on. But next we want to know how big are our red cells. And the one here that is the most important is going to be our mean corpuscular volume, or MCV, which is measured in femtoliters. The reason is this is going to tell you whether you have a microcytic, normocytic, or macrocytic anemia. So whether the cells are too small, just right, or too big. Okay, because that's going to help you determine the etiology of the anemia. So you'll be looking at, if you're a hematologist, you'll be most interested in your hematocrit and your MCV. Now, your MCV can be elevated in a number of conditions. So reticulocytosis, which I'll talk about in just a moment. If you have megaloblastic anemia, some myelodysplastic syndromes, and some medications will increase MCV. We tend to see a decreased MCV, so a microcytic anemia, when you have inadequate hemoglobin synthesis. So the classic here is going to be iron deficiency anemia, as well as thalassemia. So before I go further, let's talk for a minute about what is a reticulocyte and what is reticulocytosis. So reticulocyte count is down here. So as you'll recall, reticulocytes are immature enlarged red cells. So what the body does as a physiologic response to anemia is we're going to secrete erythropoietin from the kidneys. It's going to go to the bone marrow. It's going to stimulate the hematopoietic precursors and say, start making red cells. We're sensing that we're not getting enough oxygen in our tissues. Those red cells are not going to lollygag around in the marrow. They're going to get pumped out as quickly as they can. So before they're finally mature, they're still maybe in their teenage stage, they're pushed out to start carrying oxygen. And these enlarged cells, when we see them, we refer to this as polychromasia because they tend to still have some of their RNA. So they have a bluish cast to them, and they're a little bit big. So if you have reticulocytes in your blood, you will have, because they're larger than normal red cells, this is going to cause an increase in your mean corpuscular volume. Now, something else that we will look at is your MCH, or your mean corpuscular hemoglobin, and this tends to trend with your MCV. And so it's also, again, somewhat of a freebie. Another test that we look at is the mean corpuscular hemoglobin concentration, which is going to bring in the average concentration of hemoglobin per cell. So this is an important point purely so that you can understand better the pathophysiology of several of the anemias. So for example, we tend to see an increase in mean corpuscular hemoglobin concentration in hereditary spherocytosis, homozygous hemoglobin C disease, and sickle cell anemia. So go ahead and hit pause and think for a second why this would be. I'm going to go ahead and tell you. All right, so as you recall, in hereditary spherocytosis, you have instability of the cellular membrane. And as the cell ages, little bits of that membrane are going to get plucked out or shed off. What this means then is that although you're losing some of your membrane, you're still keeping all of your hemoglobin. So the hemoglobin concentration will be higher. Now, in homozygous hemoglobin C disease and in sickle cell anemia, remember you get those lengthy polymers of hemoglobin, and those can puncture the cell membrane, and through a variety of ion changes and water coming in, or water leaving the cell, you end up with dehydration of that red cell. So with that dehydration, you have increased hemoglobin concentration. We tend to see a decrease MCHC and iron deficiency anemia, but that's not going to be your primary index when you're looking for iron deficiency anemia. And then finally, the last thing to bring to mind is a red cell distribution width. So this measures the variability in red cell size. So healthy individuals have some variation, but in a variety of different pathologic scenarios, we have increased variability. Now, it's a little bit of a tautology to say that you get increased RDW with anisocytosis, because anisocytosis means variability in size, in cell size. But another instance where you might see an increased RDW is if you have a patient who comes in with an iron deficiency anemia. You appropriately provide packed red cells to that patient to address the anemia. Now they're going to have the microcytic cells that they've produced themselves, as well as the nice plump healthy cells that you've just given them. So that's going to increase your RDW. I'll show you a picture on the next slide of a reticulocyte so you can see that it also increases the RDW. Now, one thing to keep in mind, as I mentioned, that reticulocytes are a normal physiologic response. So this may be a question that you'll hear on the wards. You have a patient who is anemic, and your attending may say to you, is the patient ticking appropriately? And what they mean is, are they reticulocyting appropriately? Because this is letting you know that that patient has sufficient iron stores and they have sufficient nutrition that they are able to generate reticulocytes, and that there's nothing going on in the marrow, say replacement with hematopoietic neoplasm. So turning back to our RDW, in microcytic anemia, you typically will see an increased RDW in iron deficiency anemia, and we also see an increased RDW in vitamin B12 and folate deficiency. So these you're beginning to see, and maybe you can make a matrix for yourselves of what's elevated and what's decreased with which of these different diagnoses. Well, let's look at some pictures. So as I mentioned, we're talking about red cell size. There are three things we think about: microcytic, too small; normocytic, just right; macrocytic, too big. So here we have an example of a reticulocyte, which, as you can see, is much larger than the surrounding red cells and has that bluish cast from the retained RNA. So this is going to increase our RDW. Here's an example of a microcytic anemia. You can't really tell that they're too small because I don't have a lymphocyte in here for you to compare to, but you can certainly see that they are hypochromic, right? Because the central pallor is typically about a third of the diameter of a red cell. Here it's about 3/4 to 7/8, I would say. So if you take my word for it and I said this is a microcytic anemia because it's hypochromic, we're going to know this is a disorder of hemoglobin synthesis. Finally, if we look over here at this image, this is the classic finding in your megaloblastic anemias. So what you see there is we have some normally sized red cells, as well as what are called macroovallocytes. And when you see something like this is letting you know there's some sort of problem with maturation. And this is confirmed in this case where we see this neutrophil, which is hypersegmented. So it has way too many lobes. And this is a classic finding for an anemia due to folate or vitamin B12 deficiency. Now, you can also have an anemia where the cells are the right size and they have the right amount of hemoglobin. And for that, there are a variety of different causes. So you'll have to tease these out. So let's begin now by going through the different categories of tests that will help us make our diagnosis. So as I mentioned, iron deficiency is a significant cause of anemia, particularly in well-resourced countries where people get enough iron in their diet. So the primary test that we're going to be interested in is going to be our total iron binding capacity. But let's begin first with just the basic serum iron. So iron can be stored in tissues complex with ferritin, or it's transported in the serum bound to transferrin. It's also, of course, in your hemoglobin and in some of the other iron-containing proteins, enzymes. So we can measure serum iron from the blood by liberating it from transferrin and measuring it. Another way we can get an idea of iron in the blood or iron stores in the body is through a bone marrow aspirate. So you just go into your bone marrow, you take out your core, and you also suck out some of the cellular material. In an aside, another way we can look at iron in the body is if you're thinking about, say, hemochromatosis, iron overload, you can do a liver biopsy and do a stain with Prussian blue. But we don't do those for anemia. Serum iron is a relatively uninvasive test to take a look at iron stores. But our total iron binding capacity is where we're really interested. Serum iron, as I mentioned, is bound to transferrin, which is about 1/3 saturated with iron. And when our iron stores are depleted, we're going to increase our total iron binding capacity. The transferrin that is there is going to be more avid for iron. And so what we'll be doing is we'll be looking at the total iron binding capacity, our serum iron, and the percent saturation to look at the extent of our iron deficiency anemia. But when you're looking at all of these, we also need to remember that serum ferritin is considered to be more sensitive and to more accurately reflect the body's iron stores. So this brings us to serum ferritin. Now you may be thinking, but wait a second, you said that ferritin is used in tissues and transferrin is used in the serum. So why are we looking at ferritin in the blood? Well, the reason is that small amounts of ferritin are found in the serum, as well as in the cytoplasm of tissue macrophages, and it is, as I mentioned, the major storage protein for iron. So what we typically will see is that it correlates very strongly with total iron stores. So when ferritin levels are low, we see iron deficiency anemia, and we see high ferritin in iron overload. So low serum ferritin is highly specific for iron deficiency anemia, and a test you should consider if that's in your differential. Now we're going to shift gears a little bit and talk about megaloblastic anemia. I'm not going to go through this in detail as far as the biochemistry, although I will show you a very frightening figure on the next slide. But I wanted to link these two together because deficiencies in both folate and vitamin B12 can result in a megaloblastic anemia, and it's through the same process. So folate is an essential water-soluble vitamin, and you will also be aware of it in the context of decreased folate is associated with neural tube defects in the setting of pregnancy. So the fetus can have neural tube defects if the mother does not have sufficient folate. What we see with folate deficiency is going to be a megaloblastic anemia. That is the primary and most important finding. We also get a megaloblastic anemia in vitamin B12 deficiency. And you can read more about vitamin B12 deficiency in the context of pernicious anemia in the gastrointestinal chapter of Robbins. So as I mentioned, with vitamin B12 deficiency, you also get this megaloblastic anemia, but in addition, you get neuropathy due to demyelination of the posterior spinal tracts, and you can get neuropsychiatric changes. All right, so why are these linked? So this is a graphic from Robbins' Pathologic Basis of Disease, where I just want to tie them together for you. So what we see here, cobalamin is another name for vitamin B12, and vitamin B12 is necessary for the generation of tetrahydrofolic acid. Okay, so tetrahydrofolic acid is generated. It then moves on through another set of reactions, which allows the generation of DTMP, which, as you recall, is important for the formation of DNA. Okay, so if you don't have your vitamin B12, you don't generate your tetrahydrofolic acid, you don't generate DTMP. If you don't have folic acid, you don't generate your tetrahydrofolic acid, you don't generate DTMP. So this is moving through the same pathway. But there's an important point to this, which is that if you have a patient and you look at your red cell test, maybe you look at a peripheral smear, you say this patient has a megaloblastic anemia, I don't know whether it's folate or vitamin B12, but heck, I have a whole lot of folate right here. I'm just going to give them some folate and see if their anemia gets better. Their anemia will get better because the reason that you have megaloblastic anemia in the context of vitamin B12 deficiency is because you're not generating your folate. If you load here with folate, you're going to do fine with your anemia, but you won't be addressing the neuropsychiatric problems or the peripheral neuropathy. So you should always do tests for both of these in tandem. So vitamin B12 and serum folate. Okay, so shifting gears again. Right, so this is another one of the categories. Say you're interested in a hemolytic anemia. You think maybe my patient has a hemolytic anemia. Is hemolysis occurring? So these are 3 tests that you can use to sort of get an idea of what's going on. Now the first one I'm going to talk about is bilirubin. So we think of bilirubin as basically 3 pools. We have total bilirubin, we have direct, which is also called conjugated bilirubin, and we have indirect, which is also called unconjugated bilirubin. And bilirubin is primarily derived from the breakdown of red cells. So if you are breaking down a lot of your red cells, you're going to increase your bilirubin. All right. So the 2 types of bilirubin, direct and indirect, have different properties. So direct bilirubin is water soluble, excreted in the urine, and indirect or unconjugated bilirubin is water insoluble. And what we will see in a hemolytic anemia is an increase in your unconjugated bilirubin. So if you see an increased total with a push towards unconjugated, that's telling you that you should be thinking about hemolysis. All right, another value we can look at is serum haptoglobin. So haptoglobin is a protein that binds hemoglobin when it's released from red cells. And once it's complex to that, it's removed from circulation by macrophages. But if you are having a lot of hemolysis, you're going to exhaust your store of haptoglobin, which is going to allow free hemoglobin to go through the kidneys, resulting in hemoglobinuria. We also will, because we're depleting our serum haptoglobin due to all this hemolysis, these levels will fall when we have a hemolytic anemia. And then the final test that we think of in terms of hemolysis is lactate dehydrogenase, which you've seen in other organ systems as well, because it's seen in almost all cells in a variety of different levels. And when you tend to see increases in LDH in the blood, that's going to be due to some sort of cell damage or death. So if you're thinking about hepatitis, a person will have elevated LDH because of damage to hepatocytes. If you're thinking anemia, that patient can have elevated LDH due to hemolysis. Okay. Now, another set to think about are the immunohemolytic anemias, which are not tremendously common, but you need to consider them. So in an immunohemolytic anemia, what happens is you get binding of red cells to IgG or complement, which is then going to cause them to be plucked out by macrophages and removal, typically in the spleen. So there are 2 types, 2 large categories of immunohemolytic anemia, the warm antibody type and the cold antibody type. And the majority of these are going to be the warm antibody type, about 80% of cases. 50 to 60% of them are idiopathic, no idea what causes it. About 25% are associated with an autoimmune disorder or with drugs. And typically what we'll see is IgG is going to bind to red cells. It's going to result in extravascular hemolysis, a chronic mild anemia, and moderate splenomegaly. By contrast, in cold antibody type, the immunoglobulin is IgM, and it binds loosely. It doesn't bind very tightly, and it can only bind when the temperature is low, so less than 30 degrees centigrade. So that's going to be your fingers, your toes, the tip of your nose, perhaps, and your ears. So that IgM is going to bind to the red cells. You're going to get complement binding, but as that red cell then moves to warmer climes, the IgM will fall off, but the complement is still there. And macrophages will go ahead and gobble up that red cell, resulting in a mild anemia. And part of the significance of this is that it can be associated with B-cell neoplasms, so something to consider. So if you're considering the possibility of an immunohemolytic anemia, you're going to want to do the direct antiglobulin test, or Coombs test, in which we take anti-human globulin to detect antibodies or complement that are bound to the patient's red cells. Okay, so our final laboratory test will be hemoglobin electrophoresis. So this is how we use gel electrophoresis to identify the different variants of hemoglobin. So this is one looking at hemoglobin C, S, F, and A. Here are our standards here. These are different patient samples. Based on the charge of these different hemoglobins, they will migrate at different rates. So you can see this patient has one allele for hemoglobin C and one for hemoglobin A. This individual is a compound heterozygote, so both hemoglobin C and S. And this patient here would have hemoglobin S disease, so sickle cell anemia. And just as an aside, we do these both in alkaline and acidic conditions because we can get different migration based on that. So there's some additional types of hemoglobin variants. So this is something to consider if you're thinking about a hemoglobin disease. Now, finally, the last thing to give you something nice to look at is the peripheral smear. So we can get a lot of information from a peripheral smear. A drop of blood is put on a slide, we spread it out, and then we take a look. So here, for example, we see the classic bite cells of a microangiopathic hemolytic anemia. They're not really bite cells, they're schistocytes. And these are red cells that you learned about in the DIC video, that as they move through that meshwork of fibrin, they're torn to little bits. We see the schistocytes and we can think, this looks like a microangiopathic hemolytic anemia. Here we very nicely see a sickled cell and sickle cell anemia, and here is our bite cell for a G6PD deficiency. In that disease, as you'll recall, you get hemoglobin that precipitates and binds to the red cell membrane. As these cells go through the spleen, the macrophages there say, what's this? They bite it out, and there is your bite cell. Okay, I'm just going to finish up with a few questions for you to review so you can test yourself to see what you've retained from this video. So go ahead and do that. And as always, thank you very much for your time. Please follow me on Twitter, check out my website, shoot me an email, comments down below. Thank you very much.